Hello everyone, and welcome to DAAC 1319, and today we're going to be doing Chapter 12, which is Other Psychiatric Considerations in the book Loosening the Grip. And we're going to be working directly from the book today because I had, again, some technical difficulties. So I'm going to go ahead and share that screen with you, and we will do that. Okay, other psychiatric considerations. Substance abuse disorders are in themselves psychiatric considerations, and as we've talked about before, they're not symptomatic necessarily of other underlying conditions, nor are they caused necessarily by other underlying conditions, although sometimes they are. Once upon a time, Bill Wilson in the big book wrote that about alcoholics, that when we're not drinking, we respond much like normal men or other men, basically saying that there's no more psychiatric illness among a recovering population than there is among the general population. And he's wrong about that. That almost half of the people in recovery have some type of mental illness that or secondary illness that they could co-occurring disorder that could be diagnosed with them. And not all the diagnoses are made, of course, but they're there. Sometimes alcohol and other substance use mimic psychiatric conditions. If you're tripping on LSD and someone didn't know that was the case with you, they might think you were somewhat schizophrenic from the way that you acted. So being informed about mental conditions and the symptoms of mental conditions and the rates at which they occur and how they manifest in a recovering population is pretty important for a substance abuse counselor to know. And we're going to talk about that today. And immediately, first rattle out of the box, they talk about suicide evaluation and prevention. And a thing that is true and that we know and have known for a long time is that people who are going to kill themselves or who are planning on suicide will often take a drink or two or three or four before they do that, before they take any action, suicidal action. And the relation between drinking and suicide is fairly well established, that around half, maybe a little less than half of the people who do take steps towards ending their own lives are under the influence of alcohol or some other drugs. So it's the suicide rate, as the book notes here, for those with a serious alcohol disorder is around 50 times that of the general population. So the higher incidences of suicidal attempts and completions are certainly clearly documented in this population. This is complicated even more for people who are diagnosable, and a very common with co-occurring disorders, and a very common co-occurring disorder diagnosed among a alcohol use disorder population is depression. And even without the alcohol, when you're pouring a pint, a fifth, a quart, of depressant into your body every day, and you're depressed, well, go figure. But when you take the alcohol away and the depression is still there, then you have something else going on. and that's the co-occurring disorder. And people with major depression are probably the most likely of all of the diagnoses to attempt self-harm. That and PTSD. But we'll talk about that particularly here in a little while. But when we start thinking about suicide among this population, we have to consider how do we evaluate and prevent suicides among the people that we're treating. And the book asks you to consider that there are several groups to consider when thinking about suicide among a substance using population and among the population in general. And the first that they ask you to consider are the completers, those who take their lives and intended to. And there's a sad reality that's associated with this. If someone is committed to dying, and they're probably going to, unless you lock them away and have them under 24-hour suicide watch. People who are committed to dying find a way to do it. And when we recognize that there are people who are very serious about ending their lives, we have a responsibility to intervene where we can. But chances are still pretty good that someone who's going to die, jumps off a bridge or hangs themselves or puts a shotgun in their mouth. There's not going to be much we can do about that. So completers use violent means, and this is more so with men. Men are more likely to do the violent ends, the shotgun, the rope, the jumping off the bridge, what have you. Sometimes they give you no warning. It just, their methods are calculated. They're secretive. They don't talk about them. They don't write about them. They don't share that. And so that's a usually white men over the age of 50 or lonely adolescents. Second are those who succeed but didn't intend to, and these are the attempters. The book says that classically they're white women, ages 20 to 40, and they like to use pills. Pills is more of a woman's choice than is something violent or messy for that matter. Don't want to sound sexist, but that's the truth. Women don't want to be found splattered around the room. Anyway, the suicide attempt can be impulsive with these attempters, and that's another category too that you need to think of, or that I believe we should think of, is the impulsive suicides, the people who act on in the heat of the moment, so to speak. Attempters often die by mistake or as a result of miscalculation. They lose track of their dosage of the pills that they're taking or whatever, and they don't really want to die, in other words, but they wind up dying anyway. Third, there are threateners, and these are people who use suicide as an attempt to control other people, the threats of suicide. And again, this can be something that if they, this is something that is done to cause other people to behave in a way the threatener wants them to behave. I had a lady one time call me at night at home, and My number was listed in the phone book, so why not? And back in the days when phones plugged into the wall. So I got this call, and she said that her boyfriend was out at her house. She wasn't there, her ex-boyfriend, and that he had said he had taken a lot of pills, and that when she got home she was going to find him dead, and it was all her fault, and she was quite distraught. And so she didn't know what to do. So I told her, call 911 and tell the police, and tell them what the circumstances are, and give them the address and let them handle it. And so she did. She called the police, and the police called an ambulance, and they all went out to her house to find this guy sitting there drunk and drinking, and not taking any pills and not dying. And what I still today think was an ambush for the young woman, but they sent him on his way. They didn't even arrest him, which was interesting to me. But she told me that he was real upset with her because one of the cops had told him, if we get a call to come out here again and you're not dead, I'll kill you myself. So anyway, the threateners sometimes do a gesture, but it's not something that's usually serious. However, anytime someone threatens suicide, you and I have to take that seriously and do a further evaluation and see what we can discover about that. And discovering anything about self-harm is important to the population that we serve. And then there's a category the book defines as parasuicidal, and these are people who hurt themselves to relieve tension or emotional pain, and they may do things that are dangerous. For instance, cutters, people who cut themselves. And generally, when you have people who are doing that, that's symptomatic of fairly severe trauma in the past, sexual abuse, physical abuse, severe neglect, etc. And people who suffer from this may say something along the lines of, externalizing the pain. I put it on the outside instead of the inside. It also gives them a sense of control. That when I'm doing this, I know that I can end it any time I want to, that I don't have to live or whatever. But sometimes errors happen and death occur from that. They cut too deep or whatever. The impulsive type of suicides happen, they're sometimes circumstantial. If you'll remember 911, when the planes flew into the building, there was a theological debate regarding the status of people who jumped from the Twin Towers to their deaths when the place was on fire. And the Pope ruled that people who jumped from the towers to escape the fire weren't suicides, that they were doomed. There was no rescuing them, and they just didn't want to burn, and that was a good choice, basically. And so, there was no moral consequence to that. And these were people who had not considered suicide before, necessarily, that we know of. I mean, and it wasn't an act of self-destruction per se. It was in response to something else. Sometimes the emotional trauma of a situation is enough to cause people to want to do themselves harm. Back in the late 80s, I think it was late 80s, may have been the early 90s, when we still had a team called the Houston Oilers here in our area, we had a lineman who was a very talented young man by the name of Jeff Alm. And there was a recording of a 911 call that was taken of Jeff Alm. He had had a car wreck, and his friend was thrown out of the car and killed on the freeway by traffic. And Alm apparently was terrifically distraught in the moment of this happening. He was crying and pretty hysterical on the 911 call, and then you heard boom, and he shot himself right, there on the side of the road. So those types of things happen too, and there's not any real way that we, or that I'm aware of, that we can do any kind of interventions to stop someone who does an impulsive suicide like that. We might be able to talk a gun out of their hands if we're there. We might be able to talk them off a ledge if we happen to be there, but chances are pretty good we won't be. So, those are types of suicides that happen. With the attempters and the threateners there's a fairly fine line with those two too. Someone who threatens suicide, again, may try it at some point. They may up the ante, but their intent is not to die. Their intent is to get something. Their attempt is to get someone what they want, or to bind someone to them. Whatever. If you try to leave me, I'll kill myself, and it'll all be your fault. And we had a guy in Baytown who did that some years ago, and he shot himself in the stomach with a small caliber weapon. And his thinking was, this will hurt, but it's not lethal, and it'll show my girlfriend, wife, whatever she was, that I'm serious, and that, she'll stay with me and she won't leave like she's trying to do. Except it went wrong, and he died. The small caliber gun will kill you, especially in the gut, peritonitis and all that good stuff. But it was a miscalculation. A guy was arrested one time because his wife died. This was another case, and she left a note, and the police who investigated the death found the note that she said, I've taken all my pills. There was an empty pill bottle and some whiskey there, and if you love me, wake me up. And the guy went bowling or something. He left and the cops, when they questioned him, said, he told them, he said, she's been doing this to me for years, and I didn't take it seriously. And besides, the note said, if you love me, wake me up. And he said, I don't, so I didn't. Actually, they didn't have him, they let him go, but there's nothing really that can be done to, if we evaluate someone and they're not suicidal in the moment, and they walk out and something happens and they kill themselves, there's not much we can do about that. But the people who are considering it, who are planning it, who've attempted it, and who express an intent or are flirting with the idea, then we can do something. And how do we do this? Suicide is the second leading recorded cause of death in people under 18. The number one leading was auto accidents, and over 65 years of age. And 60% of those, over half of them, give some prior indication. And if you give prior indication, then you have a preventable case. If people have tried it before, talked about it before, etc., and so forth. And there are hypothetical statements. I have a friend who's been feeling down. What would you think if someone said, people, they may express this indirectly. And people say things like, it would be, I wish I had never been born. It would be better for everyone if I wasn't here, etc., and so forth. And their behavior changes. You see people doing things that normally wasn't something that they'd do. They begin getting their affairs in order, things like that. There are certain high-risk factors that can be identified. The recent loss of a loved one, being single, widowed, childless, living in a city setting and being alone, being unemployed, being non-religious. And I don't have a bone to pick with non-religious people out there. I'm just saying that, and most religions consider suicides sinful. And certainly with Christians and the Catholic Church, for instance, always considered suicide a mortal sin. That's why it's such a big deal for the Pope to say that jumping from the Twin Towers wasn't suicide. High-risk emotional factors, anger, hopelessness, that kind of thing. And sometimes people do it and to get revenge. And this is something that you'll see mostly with younger people. Father Martin, when he was still alive, I was at a lecture that he gave, and he said he told a story about a woman who came home and found her daughter hanging from the rafters in the laundry room, and she was dead, and she had left a suicide note pinned to her clothing that said, "Ignore me now." It's like an ultimate gotcha at mom, except the person who's doing the gotcha isn't going to be around to see it, to get any satisfaction from it. And then there are people who are having depression and hopelessness around illnesses, for instance. I had a cousin recently who refused any treatment for her cancer that was, pretty well advanced when it was diagnosed, and her kids were terrifically upset about that. And some other relatives, one of our other cousins said, "Well, that's just suicide," and not necessarily, but people who have chronic illnesses and things like that. My first client that I ever had, the first patient I ever worked with that had AIDS, was very advanced in his disease too. And he asked me one time, he said, I don't really want to go on with this anymore. He said, I'm dying, I know I'm dying, and it's unpleasant, and why don't I just take all my pills and end it? Why don't I just stop it right now? And truth of the matter is, I didn't have a good answer for that. He was right that where he was hopeless. He wasn't going to survive it. In fact, he didn't survive it. He was dead 6 weeks later. But, and he didn't take all his pills at one time and end it, but I guess he found some source, some reason of his own to live. People who there are fates worse than death in my book, and I have a hard time arguing with someone who is in those situations to tell them, there's some meaning, some reason that they should be alive. I'd be happy to help them find the reasons that, on their own. to stay alive, why they should remain with us. But I feel that personally I would like that choice at the end if I got it. But anyway, so chronic illnesses can drive people to suicide too, or chronic conditions that you're not going to get better from. The book asks you to recall that 40% of all suicide attempts are related to alcohol, and then goes on to say there are several correlations. And the first is chemical nature of alcohol as a depressant. And when you get intoxicated, and we've talked about this before, or at least I've talked to you about it before, you're not in your right mind. In a very real sense, when you're drunk, you're insane. And by insane, I mean you are not capable of processing information well. You are not capable of exercising good judgment. You are not necessarily operating in a realm of agreed upon reality. So you're out of your right. You're out of your right mind. You're out of your right body. You're processing information sideways, and then you do something that's not wise. And second, the alcohol creates a state wherein the integrative capacity of the brain is conditioned. You are unable to remember things and to concentrate on things. And alcohol affects the mood. When you get depressed and you put to sleep that part of the brain that gives a damn, anything can happen. So, let me see. Finally, alcohol may bring out psychological vulnerabilities that put you on the edge of reality, lead to loose associations, bring out psychosis, etc., disinhibit fears. Clinical depression is the most fertile ground for suicide, and clinical depression occurs, with alcohol, and it occurs without alcohol. Sometimes people drink to, as we know, to medicate symptoms of other disorders. But depression is where most suicides come from, either major depression, unipolar depression, or bipolar disorder too. Bipolar people have a history of suicide, and they tend to be successful when they decide to do it. There was when the selective serotonin reuptake inhibitors, the antidepressant SSRI category came out, and the first one being Prozac, and then Paxil and others. But when the SSRIs came out, the Prozac, there was a big deal about how these drugs, these antidepressants, would cause suicidal ideation and actually cause people to kill themselves because they were taking the drug. And there has been, with these substances, as with other substances, with some people, there has been a tendency toward increased suicidal tendency. However, these are drugs that are also, they're antidepressants. So antidepressants are given to whom? And the answer to that, I heard you, is depressants. People who are depressed, people who have clinical depression. And people who have clinical depression are already at a greater risk than the rest of the population for committing suicide, because this is the population that attempts it most. So there you have it. It's again the chicken or the egg. Did the Paxil cause the person to be depressed and try suicide, or was the depressed person who was going to try suicide did it anyway, even though they were taking the Paxil? So in our population, the substance users, people with substance use disorders, people that we're treating for chemical issues, are likely to have bipolarity, or likely to be depressed. So and even with the drugs that we take, we're liable to suffer from short-term depression, even if it's not something that's long-term. So we should always ask about suicide when talking with any person who's depressed, because it's a possibility. The book asks you to remember that therapists, counselors have never killed anybody by asking, but they have missed opportunities by not asking. So asking someone if they've thought about committing suicide is not going to cause them to want to go out and do it. That's, myth. When clients begin to give indications of being depression, sometimes you've just got to ask them directly. But it's a good idea to develop some kind of rapport first, so that you're not just blindsiding them out of the blue. I don't want some stranger in my office sitting there, and 5 minutes into getting to know them, I ask, well, how about suicide? Do you ever think about killing yourself? You kind of build up to that. And not every client that comes in is going to be, in this kind of distress either. But it's a good idea to check into. It's a good idea to ask some probing questions. So you ask some things and draw out a little information, and when you do ask them, always say the word suicide or killing yourself. You want to be clear. You don't want to use a lot of euphemisms, like, do you sometimes feel like it would be better if you just weren't here, or sometimes you feel like ending it all, etc. So ask them straight up, and and then consider their answers. Most of the times when I've done this, people have been very straight with me. They've said, no, I never thought about that. I was asked that. I first started a counselor. I said, no, I felt, sometimes I feel a little like homicide, but suicide, not so much. And if people do talk about having these types of thoughts and ideations, chase it further. See if they've made any plans. See if they've ever taken any action on it before. And try to diffuse the situation as practically as you can. And if I've got someone who's considered suicide or is considering suicide, I ask them for a commitment not to do it until they've talked to me again, until they've been back in my office again. And so that's one of my strategies for dealing with it. If I think that people are right now in danger of going outside and hurting themselves or hurting someone else, then chances are pretty good I'm going to let someone know. I'll let the authorities know. If your significant other's in counseling with me and he or she says, right now, today, I'm going home and get rid of that piece of garbage that I married, I'm going to ask, are you talking about divorce? And they say, no, I'm talking about Smith & Wesson. Then chances are pretty good you'll get a call from me before that significant other gets there. And the police will get a call from me before that significant other gets there. And I'm going to take reasonable precautions to try to protect you if I can, and to try to protect that significant other of a self-slaughter that they have on their mind. If the client comes up with reasons, and you can make inquiries in that regard, and I've done that, can you think of any reason why you should stay around? What would be important to you that you would, important enough to you that you'd want to live. And if the client can do that, then that's helpful too. That's putting you out in front of the consequences. It'd be more preventive, and you can bolster the client's choices, the client's reasons for staying alive, and support them in that. You cannot single-handedly keep people alive. You can't do it. It's too big it's too big for one person, especially a counselor, especially you and me. If we've got someone who's seriously suicidal, we need to do some serious referrals, making sure that we get them in the right place, if that's inpatient or whatever, to try to get them stabilized in this regard. People who are depressed, and this should be remembered, and we need to realize this, that when we're dealing with, again, with co-occurring disorders, that people who are intoxicated don't make rational decisions. Neither do people who are depressed. You can't see beyond the gloom. You can't see beyond the depression. And even people who are looking to take their life are looking for a way to end pain, to get out of the situation that they're in. Comments on safety. Can you be at risk in some of these cases? Sure you can. We live in a society where people frequently walk into businesses and start shooting people, and it's kind of horrible. But if your client is armed, try to talk them out of being armed when they're in your office. Be aware that is a risky situation for yourself. The places I worked for, up until Lee College, of course, where people can carry now, we had a rule, no weapons. You can't bring weapons in here. We didn't search everyone who came in, but that was a rule. And if you set a rule in your establishment, most of the time your clients follow it. That's something. I didn't often ask anyone, are you armed? And as a matter of fact, I can't think of a single time that I ever did. But I know that I did it wasn't really an intervention. Yes, it was. I was trying to get a guy into treatment, and he'd been in treatment. And completed his inpatient treatment, and he got out, and he was doing very well, and things were going good. And he got cocky, and he thought, well, I don't need this stuff anymore, these meetings and what have you, in treatment. And he relapsed, and when he relapsed, it was pedal to the metal. So when I saw him, he'd been on a 3 or 4 day run of booze and cocaine, and he was feeling horrible and depressed and weepy and hopeless and all of this good stuff. The circumstances of my meeting him, I met him at someone else's office. Where I was doing group, and in the group room, and I went into this guy's office with this gentleman, and I left the co-facilitator with the group, and I was trying to get. He was sitting at in a chair there across the desk from me, and the door was open. And I told him, wait just a minute, I'll be right back. And I went out to get something. I forget what I was picking up. I shut the door, and when I came back, the door was locked. And so I knocked on it, and he opened the door, and I said, why'd you lock the door? He said, I didn't. He said, it must have been locked when you closed it. And I said, oh, okay. And so I closed the door again. And when I closed the door, there was a rifle and a shotgun sitting behind the door. you know, and I kind of freaked out a little bit. I didn't say anything to the client, but I did say something to the guy whose office I was using. And I said, "What the hell are you doing with firearms up there? You had a rifle and a shotgun." And he got mad at me, and he said, "If you'd looked in the desk, you'd have found a pistol too." You know, he said, he said, "We handle money here, and, I'm not going to be robbed and murdered or have someone go." We had a pretty good little argument. I told him, if you're afraid of your clients, you need to be doing something else. But anyway, we got the guy into treatment and all that good stuff. But I still think about that from time to time. We've got a guy in crisis. He's dual diagnosed. He's been in the hospital already and treated. He's relapsed. His world is crashing on him. And there's a way out, 2 ways out, sitting right behind the door, And the implications of what might have happened still give me pause. Anyway, people begin to have hard feelings toward themselves, and we judge ourselves terrifically harshly sometimes. If a person has a record of, has a history of ideation, of thinking, of planning, of doing, of making suicidal gestures and surviving them, then there you go. What do you do if someone pulls a weapon on you? Well, I can't really give you a prescription for that. I know it's harder to hit a moving target, especially with a handgun. So, that's a thought. I've never had anyone pull a weapon on me. I've never had anyone swing down on me. I've had, a couple of threats, sometimes veiled, but nothing ever happened, and so that doesn't mean that it won't happen tomorrow. Use your de-escalation techniques. If someone's suicidal or antagonistic towards you, you use techniques to talk them down, right? Keep your voice low, don't make sudden movements, don't do a lot of eye contact with them, that kind of thing. And try to keep a non-threatening demeanor and try to talk them down. Be rational. Don't get angry. Don't be afraid. Any more than you have to. Doing a mental status examination, is looking at people. It used to be what we called oriented times 3. When someone comes into the office, you, in relatively short order, ask them questions so that they know who they are, where they are, when they are, why they are, and if all, make sure that they're oriented to reality right now. Sometimes they're not. I had a client, and I probably shared this with you before, who took a pistol down to the Wheelhouse, a recovery group in Deer Park back in the 80s, because God had told him that he was the one who was supposed to be running the place and that they were doing it wrong and whatever, and so I'm asking this gentleman, they took his gun away from him, slapped him around a little bit and threw him out, but and so he winds up in my office. And I asked him, how did God talk to you? How did you know this is what he wanted to do? Did he speak to you like I'm speaking to you? Did you get signs? Did you hear him inside your head? What happened? And he said, well, the wires in my stomach coiled really tight, and then they sprang loose and shot out the top of my head, and the weather flags told me what to do. And boy, I hadn't been a counselor long. This kind of, I thought, well, whoa, don't drink, read the big book, call your sponsor, go to meetings, going down the checklist, what should happen. I can't talk him out of delusions. He was schizophrenic, by the way. And he was off his meds. He'd been discharged from the Navy because he was schizophrenic. Which led me to wonder how he got in there in the first place. But it was good that he had been discharged from the Navy because I had the VA as an option. And so I made sure that he went down to the VA to become stabilized and get back on his meds. Do people make sense when they're talking to you? Are the senses, is it logical? Sometimes when people are coming down off of drugs, alcohol, for instance, they say things that that don't make sense. My younger brother, I went to see him when he was detoxing in a hospital one time, and he asked me if Carol and I still had that old white Freightliner that we used to drive, if we were still hauling freight and stuff like that. Well, I had been divorced from Leslie Carroll for many years, and we never had a white Freightliner, nor did we ever haul freight. So some of the things that people, and you don't have that information. You don't have that background information with people that you haven't met before who were sitting in your office talking. But as you gather information from them and other family members, then you get a clearer idea and aspect of their mental functioning. Simple mental status evaluations need to happen pretty early on, so you need to become skilled at doing that. Major categories of co-occurring psychiatric illnesses, and these are all represented in the substance-using populations. It's so great in persons with alcohol use disorders that having a co-occurring psychiatric condition is basically an expectation and not just an exception in treatment setting. And the most common one being depression. And sometimes the depressions are directly consequential to the use of the drug. Alcohol depresses the central nervous system. People become depressed when they drink alcohol. If the depression that we see in an individual is drug-related, then the further we get from the last incidence of drug use, we should see a concomitant increase in mood. In other words, the depression should become less severe the further we get away from the last drinking or drugging episode. If it doesn't, and if it increases, then we're looking at a co-occurring disorder. Second, studies have shown that the risk of having a problem with alcohol use increases 10 times if a person has schizophrenia, or 15 times if you have an antisocial personality disorder. And that's some major jumps. And what you have generally behind that is attempts at self-medication, individuals' attempts at alleviating symptomologies of their disorders with alcohol. Third, alcohol and dependence and withdrawal produce symptoms that resemble many other psychiatric disorders. And so does that intoxication. Alcohol has been called the great mimicker because of that. Fourth, the co-occurrence of a psychiatric condition significantly worsens the client's course and outcomes for individuals with both disorders. And once upon a time, we believed that you had to pick one and treat it first and then do the other. But current thinking is address both issues as simultaneously as you possibly can. Now, there are practical considerations here, which is if a person's intoxicated and out of their mind or going through withdrawal, and having withdrawal symptomologies, you got to stabilize them through that before you can do anything else. John Bradshaw, who did a lot of the inner child work that emerged in the 80s and 90s, and he used to talk about healing the inner child, and my contention was that if the inner child's drunk, you're not going to get much healing. You got to sober it up first. So you screen and assess for alcohol use disorders when you see people, and while you're screening and assessing for alcohol use disorders, screen and assess for co-occurring psychiatric disorders. Now, we don't diagnose those, and that's true, and I can hear you thinking that. Bushart, that's not our job. We don't do that. We kind of do. We make note of if we see anything that would indicate an underlying disorder, and in my diagnostic impression that I may move for, if I'm working for an agency or for a hospital, I probably have a medical director or someone there who is capable of making these diagnoses, and I will make a referral and ask them to rule out major depression, rule out bipolar disease, rule out schizophrenia or whatever that I think I'm seeing there, and let them make the diagnosis. So psychological problems are not the cause of alcohol use disorders per se, but there is secondary or reactive alcoholism. People do begin to abuse drugs, alcohol, and other drugs too. One of the things that we learned coming out of Vietnam, and we make a lot of discoveries, and there's always a lot of medical advances made around conflicts, wars, what have you. But we had people who were under very stressful circumstances, and one of our most unique wars that the United States has ever been involved in. And people would be at home, in the United States, complete their basic training. 2 days later, they're in Vietnam. If they survive, they stay there for a year. They're in combat, and they get on a plane, and suddenly they're home again. No de-escalation time to speak of. The secondary or reactive drug use that was going on there is you had people who were stoned all the time that they were in Vietnam, in country as it was called. And I knew some of them. And then, when they came home, they stopped using heroin. They stopped using the other things. And sometimes they did it with alcohol. They, replaced one drug with the next. But once they're taken out of the stressful circumstances, and if it is a reactive situation, once the stress is removed, then the response to the stress is no longer needed and it goes away, if that's the case. In many cases, it doesn't go away. And that's where you get the reactive or secondary addiction. People started using to deal with stress, and once the stress is gone, they continue using because now it's an addiction. What I do? I'm supposed to go down. Mood disorders are just exactly what they sound like. Mood disorders have to do with depression, what used to be and mania, or no feeling at all, dysthymia, and anyway, people who have manic episodes are hyperexcitable. And mania occurs with a number of different types of illnesses that doesn't necessarily have to be a mood disorder that the mania is rising from. You can have a manic episode if you're PTSD. You can have a manic episode if you're schizophrenic. So it's not, totally the realm of bipolarity. But bipolarity is what we think of when we think of manic episodes. And it's hyperexcitability, feeling good, having this sense of accomplishment. Looks like, people who are arrogant, you know, the that type of thing. Have grand schemes, do, get into risky behavior and stuff like that. But there's manic episodes, and you will rarely see people coming to you and telling you, I got to get rid of this mania, because they like the mania. It feels good. It's like being on coke without doing coke. And they have flights of thought, flights of ideas, all this kind of good stuff. People also get into a state of grandiosity. My younger brother Mike was bipolar, and Mike died. A few years back. He was 65, and he never was good at holding a job or anything like that. His idea of the ideal life was a 10 in the woods. Honestly, Grizzly Adams, whatever. I would take him to AA meetings and things like that, and get him into treatment, and he would comply with what they were doing, but he would get into this arrogant place. And a guy told me one time, he said, "Your little brother is the most arrogant son of a bitch I ever met in my life, and he has nothing to be arrogant about." It's the sense of looking down on everyone else. AA is doing it wrong. They don't know what they're talking about, etc., and so forth. And it did no good to point out to him that these are the sober people, and you're the one who's in trouble. This was a disorder that he suffered from. And I'm not making fun of him. I'm not being light about this, really. Although it did create some friction between us. It's a consequence of his illness. It's a consequence of the illness. And some of these illnesses that you see basically tell the people that they're okay. There's everybody else who's messed up. And I bet you've seen the type. Anyway, depression, we've talked all about that. Depression and bipolarity both seem to have a biological basis with chemical imbalances in the brain. And current treatments, talking cures will not cure people from being from having depression, and talking cures will not cure people from being schizophrenic, and talking cures will not cure people from being bipolar, and talking cures will not cure people from being personality disordered, and all of these good things. They can help deal with the problems of living that people have, but generally speaking, when you have these types of disorders, it's managed medically, and so we refer people to psychiatrists, psychologists, medical doctors, etc., to get on prescriptions to help them maintain mood and what have you. And that's not always a full-time and forever thing. I mean, if your depression is associated with alcohol withdrawal, you still might benefit from a mood elevator for a while to kind of get you over the hump. Alcoholism is not a Valium deficiency, however, and that feeding people who drink too much a lot of Valium is not a good idea. So, have we talked enough about depression and alcoholism? I think probably. Disorders having psychosis. You can have psychosis, by the way, with bipolarity. One of the things with bipolarity that happens is in the manic state, in the hyperexcitability state, individuals may not sleep. They may stay awake. And if you do that, then after a while, you begin to have hallucinations. Really, you begin to lose touch with reality through sleep deprivation. And this happens with lots of drugs that you use too. Methamphetamine, cocaine. If you're using a lot of that substances and staying up for 3 or 4 days and doing runs, you'll lose touch with reality too and start having hallucinations, dream awake, that kind of thing. So psychosis is a disturbance of perception and thought processes, and it's frequently associated with disturbances in function. And you can have psychosis with a number of disorders. It's most closely linked with schizophrenia, and schizophrenia has lots of different symptomologies with it, but basically if you're in a psychotic state, you've broken with reality, and delusions can come about as well, which are fixed false beliefs and incoherence of thought, disorganized speech, that kind of thing, are all symptomatic of schizophrenia. They're also symptomatic of severe intoxication with a number of drugs. So what do you do if someone's hallucinating on LSD, or who's having psychotic symptomologies around a long cocaine run, or someone who's schizophrenic? When you put them in the hospital, well, generally the treatment's kind of close to the same. You give them chlorpromazine or some other type of major depressant to make them manageable. If it's drug related, over time it will, the further you get away from the drug use, the symptoms should decrease. If it's schizophrenia, you get them on the medication and the symptoms should decrease. But you don't talk either one of them out of their symptomologies and into a cure. You can have psychotic incidences with alcohol, and generally during withdrawal you'll see hallucinosis with alcohol. Oh, and I might add here at this point too that at the emergency room with the nurses and the doctors who are trained and see this stuff all the time, they don't usually make a mistake about whether a person is schizophrenic and having symptomologies, or whether they're smoking some of the artificial crap that they call synthetic marijuana, or whether they're doing withdrawal or whatever. They're pretty able to knock that off early on. You and I, on the other hand, may have a little problem with it. Anyway, loose associations, disorganized thinking, beliefs, delusional beliefs, that kind of thing. A friend of mine used to run a homeless shelter, and she was talking about a lady who was afraid to get out from under the light, a street light that was there on the street and kind of in front of the shelter, because she was convinced that if she got out of the shelter of the light, that there wouldn't be any oxygen and she would suffocate. And the fact that other people were there talking to her and walked in and out of the light with impunity, evidence that there was indeed, oxygen there, was not sufficient to convince her otherwise. So these type of things. When schizophrenia is accompanied by alcohol use, then even coming in for treatment may be threatening, and seems to be a lot of this going around. That people are, we're seeing stuff right now in our country where people are freaked out about taking vaccines because it leads to mind control and stuff like that. I don't think they're all schizophrenic, but wow. Anyway, anxiety disorders. These are terrifically common and involve incapacitating nervousness, tension, apprehension, and fear. They're not always incapacitating. Some of these symptoms are mild enough that people can overcome them and manage to do things, to live a life that from the outside looks pretty interesting and manageable, but on the inside is frightening and sometimes unmanageable. But the anxiety can be a generalized anxiety, a fear of phobophobia, fear of fear, fear of being afraid. It can be a specific object fear, places, situations, obsessions, compulsions. All of this is part of anxiety disorders. Now, Freud first identified the anxiety disorders, and he didn't call them anxiety disorders, he called them neurosis. But the relationship of anxiety disorders to alcohol is a controversial relationship, but it's also, for me anyway, a fairly clear relationship. Anxiety is a component of the diagnosis of alcoholism, and anxiety does not necessarily go away once the drinking is discontinued. If you are taking things like Valium or Xanax for an anxiety disorder, and you can get that fairly simple, doctors tend to overprescribe these minor tranks. There's a high high prevalence of people being able, it's easy, that's what I'm trying to say, for people to get these drugs. Go into a doctor's office, talk about your nervousness, your trouble sleeping, your inability to concentrate, and zip, pop, bang, you've got Valium or Xanax. Used to, I don't know how much, so much now. I think doctors have wised up to it. You can tell them, I'm trying to drink, and I'm really trying to stop drinking, and I'm really, nervous and jumpy and shaky, and they'd give you, Zoloft or Effexor, and some Valium, and nowadays Xanax. But abstinence may cure the anxious symptomologies if it's secondary to your drinking, but the anxiety symptomologies may increase when you stop drinking too, and this is why it was pretty easy to get these drugs. You very rarely overdose on things like Valium or Xanax alone, but if you mix them with alcohol, there tends to be a higher increase of risk taking anxiolytics with alcohol. And an odd thing about anxiolytics, if I come into the doctor and tell them, that I have trouble sleeping, that I can't concentrate, that I'm always feeling nervous that something's wrong. I don't know exactly what it is, but I know it's terrible, and I don't, et cetera and so forth. Chances are pretty good that I can get a prescription for Valium or for some other anxiolytic, and that will treat the symptoms that I have. But if on the other hand I have no symptoms and I'm just partying and I decide that I like taking Xanax, I like eating bars, and washing it down with whiskey and whatever. And over a period of time, I develop a dependency on these things. And I go to the doctor and he says, well, we need to get you off of that. If I stop taking them, guess what kind of symptoms I develop? Yeah, exactly. Taking these for fun when you don't need them actually create the type of symptoms that they're prescribed to treat. So you party yourself into an anxiety disorder by using anxiolytic drugs. Weird, huh? There's also another drawback to this. These are central nervous system depressants, and CNS depressants, whether alcohol, the major tranquilizers, the minor tranquilizers, or whatever, are risky to withdraw from. These are the only basically category of the drugs that I'm aware of where the withdrawal symptoms could be fatal. The other drugs, withdrawals may be unpleasant, but they won't kill you. Withdrawing from alcohol, if you're a chronic alcoholic, could be fatal, up to 20% fatal among the people who just stop cold turkey. And the same can hold true for, not as high a percentage perhaps, but the same holds true with other CNS depressants. Another anxiety disorder that we'll see a lot of is post-traumatic stress disorder. And that's associated with the lifestyle of the alcoholic and the drug addict, the things that we do. We get in car wrecks, we get beaten, we get robbed, we get raped, we get, whatever. We're victims every bit as much as we are victimizers. Let me rephrase that. We are victims more than we are victimizers, usually. If you live through something traumatic, if you've been, sexually assaulted, if you've been beaten up and robbed, if you get into car wrecks and get shot at and shoot at people and that kind of thing, you can get a PTSD from that. And with a PTSD, it can last for a while and you make adjustments to it, or it can be a protracted period of time. Once upon a time, a long time ago, I took a course and certified in trauma resolution therapy. I didn't practice it long, and it was trauma with a big T, and they told me that going in. We're not talking about, not getting a pony when we were 7, or, almost getting run over while on our bicycle or something like that. We're a big T trauma, parents of murdered children, people who've survived wars and that kind of thing. And symptoms persist with these guys, and traumas are perceived as sometimes as having been caused by others and not by ourselves, lead to events, that are responses to the trauma. And in fact, rather than post-traumatic stress disorder, there's been some question that shouldn't that be called post-traumatic stress response, because it's a way of trying to cope with these terrible situations that we've had, that get in the way of our functioning. We have right now, and going back to what we started discussing here today, there are around 20 veterans a day commit suicide in the United States. That's a lot of people killing themselves right now. And I heard that stat and I thought, boy, that's really high. I don't think we really had that many combat troops, invested over the past few years for that to happen. And I discovered, looking into it, that it's veterans. It's not necessarily combat veterans, just people who've been in the military. And they didn't have to be in the combat zone. They didn't have to be shot at. They didn't have to be shooting at people. They didn't have to be, surviving plane crashes or, whatever. Just being in the military. That military veterans are killing themselves at a rather alarming rate. And at the same time, we have, it's weird. What constitutes a trauma is hard to objectively define because it's subjectively experienced. Does that make sense? That what's a trauma for me may not be a trauma for you. What is upsetting to me or a fear to me may not be upsetting or a fear to you. It's different for different people. The body's reaction to trauma, though, however it's subjectively experienced, is kind of the same. And people who are prone to having PTSDs, whether it's through basic training, survivor guilt, direct experiences in combat, car wrecks, rape, whatever it is that you experience, is the magnitude of that experience can be different for different people, and we deal with it differently. And screening individuals who may have PTSD, it is important for us to find out, whether they have it or not, the degree of it, etc., and make a referral. But people don't want to talk about it. It's something, and it was Dr. Freud back in his day who basically concluded that what people don't want to talk about is as important, if not more important, than what they do want to talk about. Personality disorders, there are a bunch of them. Personality disorders are traits that evidence themselves primarily in social situations. And they repeatedly and rigidly interfere with a person's ability to function in social settings or in interactions with people. DSM-5 defines 10 types of personality disorders, but the three most commonly associated with alcohol problems are antisocial, obsessive compulsive, and borderline. And antisocial, the sociopath, the person who doesn't seem to have much regard for other people, who is unable to feel empathy, who has no sense of guilt or shame, and there's a high prevalence among people who drink. That doesn't mean that antisocial personality disorders are caused by drinking. They're not. They're independent of that. Although people who drink may engage in antisocial behavior. It comes with the territory. People might not normally steal and think stealing is wrong and bad stuff like that. But when they're tweaking or needing to get fixed or, whatever, mom's purse may be fair game. People who normally don't tell a lot of lies learn to cover their tracks during their drinking career, their drug-using career, so being dishonest becomes a way of life as well. It becomes something that folks engage in very often. And if you stop drinking, a sense of responsibility, of guilt, or whatever is there. And this, and having read the big book, you know all about that. That there needs to be an inventory made, and we need to make amends to people that we'd harmed whenever we can, etc. Make restitution, make things right. So a great many of chemically dependent people that you see have very well developed senses of guilt and shame and right and wrong and all of that good stuff, even though we sometimes violate our own values. But there are certain members who have none of that. They don't feel guilty or bad about anything that they do to anyone. They may feel bad about getting caught and be angry because they have to, own up to what they've done and things like that. For a group who have antisocial personality disorders, they're not really going to get over that. Talking cure does help with them. It helps them to manage things, but it doesn't help them to cure their antisocial personality disorder, because there is no cure for an antisocial personality disorder. Also, this is a group that you can manage with medication. And so that there are some medications, particularly the minor tranquilizers, benzodiazepines, that have shown very promising with this group of people. Obsessive compulsive disorder and alcoholism, substance dependency itself does now and always has looked like an OCPD. And people who have an obsessive compulsive personality disorder, alcoholism in the big book is described as an obsession of the mind coupled with a sensitivity of the body. That means that once we think about drinking all of the time, we're consumed, obsessed with the idea of using, and that once we do use, we become compulsive with it and are unable to control the use. OCPD people are described as preoccupied with perfectionism and control. And this is perfectionism and control is at the expense of flexibility and efficiency. And people who are OCPD do things like, walk around the house making sure all the doors and windows are locked, and then walk around the house again to make sure all the doors and windows are locked, etc., and so forth. You may scrub a wall so often that the paint's worn off in an effort to eliminate germs. Things have to be perfect. Hoarders are OCPD. And you see people as good as it gets with Jack Nicholson, the guy who had to sit in the same booth at the restaurant with the same waitress every day. He brought his own plasticware in his pocket so he didn't have to use their silverware. He arranged the stuff on his table and ordered the same food every day the same way. He used a bar of soap once. He would unwrap the bar of soap, use it to wash his hands, throw it away. And next time he had to wash his hands, he'd unwrap another bar of soap, etc. So these type of things. Typically people who are OCPD, and it's distinctive from OCD, by the way, they're not bothered by their rigid behavior patterns as other people who are bothered by it. OCD, obsessive compulsive people, have some of the same characteristics, but OCD people are bothered very much by intrusive thoughts and compulsions that they can't control. And it's the OCD that most closely resembles resembles alcohol use disorder. So when you are evaluating people and your clients, it's a good idea to be able to look for these sort of things and see what types of symptoms may be there. And again, this is referral time. This is not time for me to decide. I know what to do with an OCD or what have you. Borderline personality disorders are people this is generally a condition. Dr. Freud also described this condition is something that is a type of attachment disorder, really, that because is believed to be rooted in early childhood and the fact that infants didn't bond properly with their parents, their mother, particularly caregiver, and they have a lot of problems. People with borderline personality may act impulsively. They have multiple suicide attempts, exhibit inappropriate emotions, whether it's intense anger or a facade of affection. They feel empty, disconnected, they're bored, they have mood swings, often use alcohol in chaotic and unpredictable patterns. They don't seem to do well in treatment in most cases, but for these reasons, we're trying to manage their alcoholism. And among those seeking treatment for alcohol dependence, now this is a kind of a startling stat, 13 to 28% will have this personality disorder. And with people who have borderline personality, the majority of them diagnosed with this condition are female. Again, it's important to try to, separate out things that are alcohol related from things that are personality disorder. We can do something about the alcohol related. Personality disorder, not so much. I mean, if you're working with someone like this, they demand honesty and refuse to hear it. They demand loyalty and refuse to accept it. They tend to attach to one person at a time. And so they have a history of poor relationships. They tend to reject other people before these people can reject them, etc. Again, it's kind of a miserable way to be. When we see this, again, we can, and like I said, people with borderline personality tend to attach to one person at a time, and if you're the counselor, that you might have an experience of they're putting you up on a pedestal because I've been to see all of these other people, psychiatrists, doctors, etc., and so forth, and none of them understand me like you understand me. You really get me, and you have been the answer to my prayers, you're the solution to the problems that I'm having. And all of this can feel pretty good, except one, oh poo, and all your atta-girls go out the window. And now you're not on the pedestal anymore, you're something they're trying to wipe off the bottom of their shoe. And they're swinging from one relationship to another relationship to another relationship. Again, that's symptomatic of the disorder. That's not throwing off on any individual. Attention deficit hyperactivity disorder is real, and I think sometimes it's misdiagnosed that kids are getting treated for something that they don't have. There's a debate out there about whether drugs to treat attention deficit hyperactivity disorder may cause substance use problems later in life, or if the ADHD itself causes substance use disorders later in life. But the failure to adequately treat ADHD among some people tends to set them up for substance use problems as adults later on. Psychiatric disorders are also due to medical conditions. You can drink yourself into psychiatric disorders, as we've talked about. Delirium tremens from withdrawal, Korsakoff psychosis, Wernicke's syndrome, cerebral atrophy, all this associated with alcohol use, dementia associated with use of ecstasy and things like that, and destruction of serotonal neural pathways. There's all kinds of disorders that can come about by drug use. And cognitive defects, alcoholic dementia, and all of that. We talked about that in the medical conditions. Drug problems in combination with alcohol disorders is another issue too. Sometimes they get overlooked. A person's drinking so much that you tend to forget that they're also smoking a ton of weed, eating pills by the handful, etc., and so forth. When I sobered up, back in when dinosaurs roamed the earth and what have you, if you had a dual disorder, if you were in an AA meeting, they might not want you to talk about your drug use. And some wise old bleeding deacon will say, well, we don't know about all that other stuff, boy, but we're here to talk about recovery from alcohol. And same at Narcotics Anonymous. I'm an equal opportunity condemner on that one. If you go to NA and talk about your drinking, there'll be someone say, well, I don't reckon I came here to hear an old drunkalog, kind of thing. The reality is that drug problems occur with alcohol use disorders really frequently. And alcohol-related problems alone are, becoming rare. And people who only use one drug are becoming rare. And I don't think that anything has really changed other than our willingness and our ability to see that these are combination issues. They've been there all along, and they've created problems in recovery all along. When Palmer Drug Abuse Program first got started, they were meeting in the basement of the old Palmer Episcopal Church, and began to spread out from there. It was all about drug abuse. It was all about people doing heroin and taking pills and dropping acid and stuff like that. And you could come there and sober up from all of those drugs, and they didn't have a prejudice towards alcohol use. Alcohol is an accepted drug, and cigarettes. You could go there and smoke and drink, and and here are all these recovering people who are kind of loaded on booze and smoking cigarettes and stuff like that, and it's getting in the way of their recovery from the other drugs. A drug's a drug, actually. And if you've got someone with an alcohol problem, look for other substance problems too. And if you've got someone with other substance problems, look, see if they have alcohol problems too. And where it really gets kind of tricky is when you're looking at people who are drinking and taking Valium and stuff like that, it's real hard to get a user sometimes to wrap their head around the idea. If you are addicted to alcohol, you are also addicted to Valium. Well, wait a minute, I've never taken a Valium before in my life. Well, that's true, that's incidental, but when you do take it, you'll have the same type of problems with it because it's the same drug acting in the same part of the brain, etc., and so forth, the central nervous system depressant. So what you have really is a cross addiction. And if you've got someone withdrawing from benzodiazepines and you give them a few drinks of whiskey, that should alleviate their withdrawal. And that's why you also wind up, if you go into the hospital withdrawing from alcohol, you get benzodiazepines in your yellow bag to keep you from withdrawing, keep the withdrawal symptoms manageable. Then there are behavioral addictions. Oh my goodness, gambling, anorexia nervosa, sex addiction, compulsive spending. And some of these kind of fall into the OCD category too. With a lot of guilt and grief associated with it. Pornography addictions, food addictions, there's a lot of them. And we will see people who suffer from this in the course of our professional careers. And we'll be expected to deal with people who suffer from this in the course of our professional careers, in the sense that we identify it, make appropriate referrals, work concomitantly with people that we refer to, etc. Homelessness, alcohol use, and mental illness. Homelessness isn't an illness, but a lot of people who are ill are homeless, particularly with chronic mental illness. Now, homelessness occurs to people who are not mentally ill too, it's astonishing how close some of us are to that. We don't have to miss many paychecks at all to wind up not being able to pay our rent or our mortgage and our car notes and things like that, and out on the street. If you don't have a job and you're homeless and your car's repossessed, what now? Well, why not drink, huh? Some people are homeless because they drink, and some people drink because they're homeless. But there's, an increase of substance use among that population. And the deal is with homelessness, it can become a cycle. People go into a homeless shelter or to a mental health shelter, and they get stabilized. They're given medication. They go out on the streets again. Maybe they're doing well. They stop taking their medication. They begin to self-medicate with alcohol or other drugs. They wind up in trouble again, and back around it goes. In Texas, the biggest resource where we house most of our mentally ill people are jails. And so you can go to any jail in Texas and, find someone who's diagnosed mentally ill in there, and often much more than one. Psychotropic medications also are a consideration. A thing is that if you get to know some of the medications, some of the antidepressant medications, the antipsychotic medications, anti-seizure medications, etc., and so forth that people are taking, then just by asking them what kind of medicines they're taking, you get an idea of what's going on with them, what their diagnosis should be. Sometimes people are all gung-ho for, can you give me something to make this better? And other times people are, oh no, I don't want to take anything. we do not prescribe, you and I. That's a call for a doctor, and whether they're taking the medication or not really is a call for the patient. We can listen to patients if they're concerned about their medication, and I have done that. I have suggested to our clients that they go back and talk to their doctor about the medication that's prescribed to them and their concerns about it, and see what the doctor has to say. He'll probably either justify the type of medication that you're taking and the amount that you're taking. He'll be able to speak to you about that, or maybe he'll address your concerns and you can make adjustments to the medication or whatever. Sometimes antipsychotic medications, and they're getting better with it now than they ever have been before. And by that I mean big pharma and physicians who prescribe this. But they've had side effects, and some of these side effects have been disabling. A heavy sedating side effect where you're listless, can't concentrate, want to sleep all the time, etc. Or you may get things like tardive dyskinesia, where you're making jerky body movements and quirky facial expressions and things like that. But there's a lot of reasons, a lot of side effects that people have brought forth as reasons for them not wanting to take these drugs. What you're looking at right now on your screen is over here is a little common abbreviation on prescriptions and dosages that you might find interesting. And on the next page, antipsychotic medications and their risks of abuse. And they're not really at high risk of abuse. Most people don't like the effects of antipsychotic medications, and if you use them, it's generally a jailhouse situation where you can't get anything else. Anyway, antipsychotic drugs are much likely to be abused than other psychoactive agents for that reason. Antidepressant medications, there are several varieties of them. One is selective serotonin reuptakers, which basically increase levels of serotonin, and that elevates mood. Serotonin norepinephrine reuptake inhibitors, similar to the SSRIs. Monoamine oxidase inhibitors, and these are all inhibitors. And what that means is they increase levels of one thing by decreasing I misspoke. Two of the three are inhibitors. The SSRIs and the MAOs inhibit. That means that I'm fumble mouthing. SSRIs are selective serotonin reuptake inhibitors. They inhibit the ability of the mechanisms to reuptake serotonin. That means they increase serotonin by causing more of it to be available in the synapse. Tricyclic antidepressants are also used commonly. These are not, and they're called tricyclics not because they do three things, but because they're based on the three-ring molecular structure of the phenothiazine molecule. SNRIs are inhibitor drugs, but they're serotonin norepinephrine reuptake inhibitors, and they cause serotonin and norepinephrine to be increased in terms of availability. And their actions are similar to the SSRIs and the tricyclics, all of which cause these excitatory neurotransmitters to be available through suppression of a mechanism that reuptakes them. Another category is the MAOIs, the monoamine oxidase inhibitors. You've got to be careful not to have cheese and some other things with that. And they have some side effects. But they're used for more severe cases of depression, and these interfere with the process of monoamine oxidase, which is an enzyme that destroys neurochemicals, particularly serotonin. And they increase levels of serotonin by inhibiting the effect of MAO. How do you know which one's the best one? You really don't. It's not our call. Physicians will prescribe these medications with people, and if you've ever undergone this type of treatment, then you know that they kind of experiment with it. They hit on the right combination of things and the right amounts to get the maximum benefit. And it can be frustrating for the person who's being treated with this. And you got a couple of pages there of antidepressants that you can look over. Mood stabilizers are things like lithium and other drugs that help people stop swinging back and forth between extremes of moods, to stabilize it, to bring it to a moderate way of being. And there's some anti-convulsive and mood stabilizers for you. Anti-anxiety agents, and this is a huge categorization of drugs. This is just a few of them. They're also referred to as minor tranquilizers, and Klonopin, Xanax, Valium, Librium, Ativan, Serax, Buspar, all of these drugs. There are dangers in terms of possibility of abuse, because people take them who don't need them and mix them with alcohol, and that creates overdose situations. You don't get a lot of overdoses just on benzodiazepines, but once you mix them with alcohol or with other CNS depressant drugs, then that risk jumps way up. And finally, anti-insomnia agents. And these are things, generally they've been barbiturate, Seconal, secobarbital, phenobarbital, etc., which is also used as an anticonvulsive. Sometimes we have some real sleep disturbances in early sobriety. People can't sleep, they can't fall asleep, they don't stay asleep, etc. Anyway, letting people know about this and knowing that it's normal and that they're not going crazy and this isn't going to be a long-term consideration is pretty crucial in early recovery and in counseling. It removes the mystery and takes the fear out of it. Also, as people are very likely to want to reach for things to help them sleep, and some of the things that they reach for are kind of misused, like people may start taking Benadryl, for instance, to go to sleep rather than to alleviate any kind of allergy thing, or might start taking NyQuil to go to sleep instead of and that tends to be playing with fire. The thing about insomnia agents is any central nervous system depressant can be used as a hypnotic, something to put you to sleep, depending on its dosages. You up the dosages of the CNS depressant, it brings about drowsiness and then sleep. But a problem with that is people may sleep too hard, and by that I mean not necessarily long, not necessarily oversleeping or sleeping more than they expected to, but sleeping in a way that tends to complicate the insomnia rather than fix the insomnia. when you drink yourself to sleep, you tend to suppress REM sleep, the sleep where you dream. And if you watch someone who drinks themselves to sleep, you'll see that their sleep can be restless, that after a few hours, when the alcohol starts wearing off, they begin to toss and turn and kick and what have you. So a problem with taking medication to induce sleep is the more you do it, the more you need to do it. And then it becomes kind of a self-perpetuating problem. And it can cause rebound insomnia. You can address this behaviorally. We've talked about that before with the alcohol-using client and the recovering client, talking to them about their use of sugar, caffeine, nicotine, and talk to them about their diet, and talk to them about exercise, and talk to them about maintaining bedtimes and that kind of thing, all of which will be helpful towards sleeping. And that is about all I want to say about that. Actually, there I am. I hope that worked. I won't really know until I spot check it, playing it back a little bit, but I think it did. And if you're seeing me saying this, it did. Anyway, okay, we're getting close to the end. I hope you're enjoying the course and getting a lot out of it. And I'll see you next time.